This is a case of knee arthroplasty done in a patient with a sclerotic bone disease. It was a bilateral TKA done. Patient was a 53 years male. He had pain in both knees, joint and tenderness, varus deformity. Knee range of movement was limited. Patient also had a low hemoglobin. This was the this was his clinical video before surgery. So varus deformity, middle age, well built. So that is the X-ray picture, AP and lateral. Shall I go ahead? So you can see that bone inside the bone. That is a clue and a sign I am giving. So that is the standing scanogram. So I will stop here. So these are the findings. Obviously, there are sclerotic bones, and the scanogram shows like this. It is a varus deformity. So what are your thoughts? What are the precautions we are going to take? Alignment philosophy, of course, it differs. Or you want me to continue with the presentation?
No, sir. We'll ask some suggestions, sir.
Okay. Do you pick up anything else apart from what I have said?
Osteopetrosis, what is the patient's complaint?
Knee pain, sir. He came like any other OA patient, pain in both knees with that waddling gait.
And any history of fractures, non-healing fractures prior to this?
No, sir.
No injuries, no plating, nothing done.
Nothing, sir.
Some form of osteosclerosis, but epiphysis is not sclerotic. In the tibial side, below the
Good
epiphysis.
observation, sir. Epiphysis is spared mainly on the left side.
But below the epiphyseal scar, it is more sclerotic than the tibia.
Yeah.
And the femur, it doesn't look like that. Even epiphyseal area is sclerotic.
Even I observed that, sir, in my first.
Intramedullary drilling may be very difficult. I will do by like a kinematic alignment without drilling it. Both sides for tibia and extramedullary, and based upon the surface markings, morphology, we will cut it and accept the whatever the virus without any release.
So you will do with the patient-specific instrumentation. That is what you are telling.
On the regular instrument, VP itself will do. It will do wonders. Nothing.
So you will modify and use it like patient-specific instruments. That is what you are telling, sir.
Same instrument I am using it for all cases, irrespective of anything, age, gender, everything.
You are correct, sir. We have to avoid intramedullary drilling. Any other points to be added? So this is an interesting finding in osteopetrosis. We see bone inside bone, and as we can see, the medullary canal is not visible and it is almost absent or very narrow. Anything on the scanogram? So that is the degree of deformity actually. 20 degree on right and 18 degree on the left. So I just want to highlight this part of the scanogram. Anybody want to comment?
Was the patient in alendronate or any zoledronic acid like that?
No, sir. No, sir. He was not on any previous medication. In fact, he doesn't know that such condition exists.
Surprising for an osteopetrosis not to have a fracture and not being ever treated. So for a 55-year-old with only varus deformities is pretty surprising.
Sir,
Usually the neck is the one which is first affected.
sir, I approached this case as a sclerotic bone disease. Osteopetrosis was my working diagnosis. That's all. Osteopetrosis is one of the condition which produce sclerotic bone disease.
Okay.
Because genetically to narrow down to osteopetrosis, it's little difficult because there are bunch of deformity diseases which look similar to this. But we can appreciate this bowing in the proximal femur. That is quite obvious. This bowing. Do you think it plays a part? Anyone wants to comment? Okay, I will move on with the presentation. So, a working diagnosis was osteopetrosis because renal osteodystrophy also looks similar to the features in the spine, but only difference is in osteopetrosis, this differentiation between sclerotic and normal bone is sharp, whereas in renal osteodystrophy, the differentiation is blurred. So that is why I thought, okay, it could be osteopetrosis actually. So we all know that in osteopetrosis, osteoclast functions fail. So we have a sclerotic bone. At the same time, the bone is abnormal and brittle. No medullary canal or narrow medullary canal. So the chance of intraoperative fractures are more because of brittle bone. And since it is a sclerotic bone, if we drill too much and faster, there is a chance of osteonecrosis. And since the blood supply is less, the chance of osteomyelitis is also high. So since medullary canal was absent, we have these options for such patients, either robotic assisted, computer assisted, or portable navigation devices, or patient specific instrumentation, or customized cutting blocks, like what Sankaralingam sir has told. But in our case, we very well had a robotic assistance, but only thing is putting the pins in the femur and tibia will be little time taking and difficult, that we have to keep into consideration. So now coming to the technique, I always have been in the mechanical alignment philosophy guide. So we aim for neutral alignment plus minus 3 degrees. Same goes for the implant position also, component position also. When it comes to the coronal alignment, we did sequential medial release. What we do like classically to balance the gaps in extension. And since it is a varus knee, to balance the gaps in flexion, we used gap balancing technique. And we all know that with Wellis robot, we use this spring tensioner to open up the gaps so that the computer can measure the gaps. Once the gaps were measured, by using this 3D virtual balancing, we we managed to position the femur such that the gaps are balanced. Like basically, it's a gap balancing technique. Now, another interesting factor here is, so in the scanogram, we showed that the proximal femur is bowed. So if we are doing regularly for the sake of discussion, we assume that we are going to use a conventional instruments and do using a intramedullary rod technique. Normally we use a 5 to 7 degree distal valgus cut. However, in this case, since there is a proximal bowing of the femur, the angle between the anatomical and the mechanical axis was 14 on the left side and 14 on the right side and 12 on the left side. So, which means if we take a regular 5 to 7 degree distal valgus cut, the patient may end up with a severe varus on almost both the sides. So, in such cases, when you do with conventional technique, we have to take almost double the amount of valgus cut. However, in conventional instruments, the maximum valgus cut you can take is 9 degree in attune instrumentation, and most of the instrumentation it is are 9 or at most 11. So, which means conventional instruments may not be adequate when you want to get a proper 90-degree cut. So, this is one of the limitation of the conventional instruments. Anyway, we have been doing this with robotic or navigation guided, so it was not a issue for us. Now coming to the tibial cut, like how Sankaralingam sir told, the epiphysis was paired in this. And I was going through literature. There are some diseases like osteopetrosis where the epiphysis is paired. So we were lucky enough, we took the tibial cut without much of a difficulty and without any much delay. And as we were doing the femur cuts, we had this chalky type of consistency. We came to know that bone consistency is like chalky. And since the chance of fracture is high, I wanted to avoid a PS implant, because when you impact, the chances of condyle fracture is high. So we thought we will go ahead with the CR implants. So we tried to retain the PCL. However, in Attune, if accidentally you remove the PCL or you intend to remove the PCL, you can still use a CR insert, and that is what the company claims. But I want to add one thing in that: if suppose the PCL is sacrificed, we have to make sure that the mediolateral balancing is perfect and the insert is snugly fit in flexion. Otherwise, if the PCL is also lost and the mediolateral balancing is not proper, if the implant is not snug fit, the chance of posterior dislocation is high. And coming to, so in femur side, we managed without taking a box and with a CR implant, and that was easier. In the tibial side, we had difficulty in preparing the tibial stem and for the keel. So if you see here, we have been trying to drill, but the drill was not going. So we used the drill bits and put multiple drill holes. And to avoid necrosis, we were constantly irrigating with saline. And then we managed to drill. And the main thing is when you prepare for the keel, this is where can things go wrong very badly because of the brittleness of the bone. So what we did is with the osteotome we try to take off more bone before pushing the keel punch, and that is the keel punch finally we got without without any iatrogenic fractures. But this I learned hard way, because earlier in one of my cases, when when the medial bone was sclerotic, and I was doing my keel punch, and I was little careless, and then I landed up in committing a iatrogenic fracture. So then I had a very difficult time. Then we had to plate, and this is 1.5 years after the initial surgery, and luckily the patient recovered well, and the implant was holding good actually. So on a safer side, it is better to prepare the keel with the osteotome rather than blindly banging it. And on the right side, the epiphysis was not that normal. It was also sclerotic. This was the tibia prepared surface. So for better cementation, we had to drill holes in that sclerotic bone. So this is the post-op X-ray. As you can see, the CR implants, and this is a primary attune. So this is the post-op scanogram. So we aimed for mechanical axis, and so luckily we got we achieved what we aimed for actually. So this is the pre-op and the post-op pictures, and this is the post-op videos. Even before surgery, he had some stiffness. We managed to get up to 100 degree or so in both the knees. So coming to literature review, clinical manifestation, we have to be aware of sensory motor, hearing loss, psychomotor retardation, hepatosplenomegaly, cranial nerve palsy, especially when the sclerosis is too much. This can compress these nerves. So you have to be aware of this. And patients also can have pancytopenia because of loss of bone marrow. In our case, the hemoglobin was very less. which we managed with just transfusion. The hematologist told just transfuse and refill the hemoglobin. And this is the bunch of differential diagnosis. But some of the familiar things, terminologies, what we know is a renal osteodystrophy, where we can have a Ragger-Jersey spine, Paget's disease, melanostosis, or candle bone disease. So this all can cause sclerotic bones. So the take-home message is you should have adequate number of saw blades and batteries when you are dealing with such cases, because we won't know how much time it's going to take in the OR, and we have to use low speed drilling with copious irrigation to avoid osteonecrosis. And so you should have alternative methods to take the distal femoral cut. And then if the bones are sclerotic, to put multiple drill holes for better cement interdigitation. And when you choose the implant, you choose it wisely. As much as possible, try to avoid a PS implant, and then if possible try to avoid patellar resurfacing because of the brittleness of the bone. Thank you.
Can I say some words about
Sure, sir.
Sure, sir. Sure,
Yeah,
sir.
definitely, sir.
Sure.
Definitely, sir.
one is it is a very well proven fact that poliomyelitis with fracture neck of femur, if they are fixed, 99% you will get a good union. You don't need to do any arthroplasty in those individuals. And we are really taking a big risk of dislocations. To avoid dislocation, we are going to put dual mobility. In a younger patient, dual mobility, how long it is going to survive, we don't know. After the failure of that hip replacement, what is the future, we don't know. Now, I am not telling on my offhand. I have my own series of patients whom I have treated with fixation. Even after 2.5 years later, I have done valgus wedge osteotomy to get a healing in those individuals because the muscle power around that, they do not distract the fracture site. And Ganga Hospital have presented a large series of 34 patients in TNOA con, which was conducted in Salem, where they have done only fixation of poliomyelitic fracture neck of femurs, and they have got a good result out of it. So the message is you have to do fixation. You have to convince the patient that the patient's fracture will heal, and he has to go about once the fracture heals to do his job. That is one thing which I wanted to see. Second thing is anterolateral approach is not a sin. Anybody who is dealing with valgus deformity, he can do the anterolateral. You have to see the steps which are shown in the Keblish publication. You can do a very nice release, and the pad of fat has to be preserved because that will be required during the closure of the wound. And epicondylar osteotomy is indicated when, while balancing, if you extend the knee and if you find that the knee goes into valgus, at that time, the LCL is still tight, then you do a valgus, the epicondylar osteotomy. Okay, you don't do routinely osteotomy. As Bharat said, you should do a good lateral release. Posterolateral corner has to be released, like what we do on the posterior medial side for the varus. You do on the valgus side, release all the structures, as well as take out all the osteophytes there. Most of the time, you will be able to get things all right. You do your pie crusting of the IT band, and they will be you will be able to balance the knee and use the intercondylar
Epicondylar axis.
axis, as well as the anterior line, which we call it as, forget the name.
Wide side.
Oh, white side.
Right side's line.
Right side. While resecting the femur, these are the two landmarks which anybody. And when Raj
Sir,
has
I was
got the,
just sorry. I'm sorry interrupting you. I was talking about lateral epicondylar osteotomy only in rigid cases. I was not specifically talking in this patient, sir. So in this patient, I would have in fact gone with a CR. I was talking wherein it is very rigid and MCL is lax and you are not able to balance. I will not be going and releasing tissue after tissue. I would rather do an epicondylar osteotomy so that the tissues are all intact when it is rigid and in severe valgus and you're not able to balance. Not in this patient.
That is what I was also telling.
Yeah, yeah.
You are going to do the soft tissue releases first, and once you have done everything, usually the balancing is easy in flexion. Balancing is difficult only in extension,
Extension,
in
correct.
valgus knee. And Raj Khanna's case, osteopetrosis, I am wondering how usually osteoporotic patients or pediatric patients, they may have awful deformities, but they don't get any pain in the knee. But this particular patient has got a varus knee, and he has got a joint line varus. The long leg X-rays itself showed that there is a varus at the level of the hip, which is quite common in pycnodysostosis and osteopetrosis. In both condition, you will get the varus deformity, which is accentuating factor. And when you are using a navigation-based robot, the placement of the femoral component and all will be accurate, and you will not have. Raj Kanna has got the experience of both navigation and robot, and there should not be a big problem as far as the case is concerned. So thank you very much for listening. I will see you all during this 5th and 6th meeting.